We are so happy to be on the third day of our lovely conference with our President Randa and our esteemed board. It's my honor to welcome the medical plenary, Dr. Jenna Nikolaides. Oh no, I've got more to say, but you can come up, and we'll introduce your parents together. This is Mr. and Mrs. Carionis in the front row. Let's have a nice hand for them. They came all the way from Northbrook, which is, you know, with Chicago traffic, at least 17 minutes. So we're so glad that they're here. So Dr. Nikolaides is a toxicologist, which, as she's told her parents over the years, is a specialty of emergency medicine that specializes in poisons. Her favorite poison is salicylates, and she's unfortunately not talking about that today. I was hoping, she would give us an overview of toxicology from the perspective of salicylates and how they're very educational on prevention and treatment and all kinds of things in toxicology. Instead, she's going to talk to us about the passions, which is also really cool. So, welcome, Dr. Nikolaides.
So I apologize if this talk is a bit overwhelming. I'm trying to synthesize my entire field into one talk. And I am a toxicologist, but I'm also a professor, assistant professor of addiction medicine at Rush. Rush is our hospital downtown in Chicago. So I'm going to talk about the disease model of addiction, and whenever I try to synthesize an entire field, I take a perspective from history. So you will see the outline of this talk is the history of the disease model of addiction, the neurocircuitry of addiction. I'm going to talk about how we treat addiction and where, and then substance use as a public health crisis, the rise of addiction medicine and harm reduction, and then some controversies. That's a lot, but I promise I will go quickly and save time for questions, hopefully. All right, so this is the whole topic of this conference, right, is what is addiction? It's been debated since antiquity. Is it a sin? Is it a crime? Is it a disease? What are the treatments? Are they medical, legal, moral? And what is the cause of it all? Is this just an individual's psychological vulnerability? Or is it the substance? Are there social factors? I'm going to talk about the disease model. All right, so over the course of history, alcohol has been consumed since 10,000 BC. The ancients had gods of wine. It is mentioned in religious texts, not only wine, but the concept of drunkenness as a negative effect on behavior. That got articulated more in religious texts. But we have continued to use these substances for many purposes, like alcohol, nicotine, and caffeine have been used in many socially approved ways. Opium, cocaine, cannabis, hallucinogens, they've had religious and medical uses. But drunkenness really became more of a problem beyond the individual. It became like a societal problem during the Industrial Revolution, and that's because people started to be organized as workforces, and you had an established work week, and it became a problem now if your workforce that shows up in the factory is drunk. And it's not just an individual problem anymore. And then wars. Wars have spurned bursts in the use of substances. The first ever opioid crisis in the United States was after the Civil War because of so many soldiers needing opium for being wounded. And subsequent wars have caused spikes in amphetamine use and opioid use. All right, so historically, psychiatry needed to kind of organize itself, and the first ever sort of attempt at that was the French psychiatrist Philippe Pinel, and he created a taxonomy for psychiatric disorders in 1806, and he categorized mental illness as 4 types: melancholia, mania or insanity, dementia, and idiotism. He identified alcohol as a cause of melancholia. Then Dr. Benjamin Rush, that is the namesake of my hospital, and also he was a signer of the Declaration of Independence and the founder of American psychiatry. He was the first ever to hypothesize addiction as a disease itself, and he created the first institution devoted exclusively to the treatment of alcoholics in Boston. This is Benjamin Rush, and he wrote an inquiry into the effects of spirituous liquors on the human body in 1784. It was really ahead of its time in terms of describing addiction as a disease, and it actually ended up resulting in the first temperance movement in the United States. Freud, who was the other biggest player in the development of psychiatry, he believed that dependence on alcohol was just sort of another form of dependence. He basically said if you were kind of an underdeveloped person in your childhood, meaning you kind of never developed full independence as an individual, then you became dependent on other things later in life, and he equated it to dependence on other people as well. If you're dependent on alcohol, you're just dependent on other things because you're kind of like weak. But he believed in cocaine as, as something that could have medicinal potential, and he experimented with himself, and this is his work, Uber Coca. He actually experimented so much that now we recognize probably Freud had a cocaine addiction. All right, I'm not going to go through everything that happened, but at some point we decided we're going to treat this societally and not just as an individual. And so this was the first attempt at that was the temperance movement. Like I said, Dr. Benjamin Rush's work ended up influencing temperance movement. And then the second wave of the temperance movement was really from women's rights activists, because they believed that drunkenness really led to a rise in domestic violence. And so in order to protect women, women took up the cause of temperance. After that, this really became kind of laws. The Pure Food and Drug Act in 1908 really started to name substances that needed to be regulated. And the USDA's Bureau of Chemistry, which was the precursor to the FDA, started to name certain substances were addictive and dangerous. Ever since then, it's just been sequential laws trying to control the problem more and more, leading all the way up to, obviously, prohibition, which was a big moment in the United States from 1920 to 1933. And then beyond that, in 1971, Nixon declares the war on drugs. And so it gets increasingly punitive and increasingly legal, the treatment. And then by 1971, the communication becomes more warlike. And so this is where everything since then has been very, crime and punishment based. All right. Alongside that, psychiatry started to organize itself, and in the 1910s to 20s, the American Psychiatric Association starts working on a standard nomenclature for psychiatric diagnoses. We actually didn't have that. These terms like melancholia, didn't have a unified diagnostic criteria. So in 1930s, the standard classified nomenclature of disease was the first ever attempt at this, but it mostly focused on patients that were committed in asylums. 1952, you get the first ever DSM, which is the Diagnostics and Statistics Manual of Mental Disorders. DSM-1 really tried to expand its disease diagnoses beyond committed patients to just kind of everyday mental illness that you might be suffering from even still at home, so things like mood disorders. And it's the first broad-based recognized nomenclature. It does include drug and alcohol intoxications as brain syndromes, and it includes addiction as a sociopathic personality disturbance. 1968 brings us the DSM-2, and they recategorize alcohol addiction as something that isn't separate, and you can have, it's not a separate psychiatric diagnosis. You can actually have a psychiatric diagnosis of like depression or mania and alcohol addiction. And it also started to flesh out the definition of dependence with a more biological understanding. But DSM-1 and DSM-2 were plagued by the fact that they didn't actually give diagnostic criteria, and so people still felt that DSM-1 and DSM-2 were not generalizable enough where everyone could be on the same page. So the biggest overhaul was DSM-3, which was in 1980. And this changed the entire efforts to be more descriptive rather than based on etiology. So up until that point, people were trying to categorize mental illness by what caused it, and then at DSM-3 was, let's just describe symptoms as we see them and categorize them that way. This really became a huge expansion, many more diagnoses, much more emphasis on diagnostic criteria, and much more incorporation of research data. Substance use disorders was now given an entire separate section, and it tried to separate out the terms substance use, substance abuse, and dependence, and tried to recognize how one could use substances in a non-pathological way. It also initially said you can only be dependent on certain substances like alcohol and opioid, and actually said you can't be dependent on stimulants or cannabis. That got revised in 1987 with the DSM-3 revision, where they changed the definition of dependence yet again to say, no, you can be physiologically dependent, but also behaviorally dependent. And when they changed that, it meant you could be dependent on many more substances. DSM-4 in 1994 included substance-induced disorders as a separate category. So this includes things like substance-induced delirium, substance-induced psychosis, substance-induced sleep disturbances, and substance-induced mood disorders. And this is separate from just the addiction diagnosis. And it also changed the definition of dependence again, meaning you didn't have to have physiologic tolerance or withdrawal. You could actually just have the compulsion. We are now at DSM-5, and this is what I'm using in my everyday practice. DSM-5 was yet another overhaul, and it began this section with this preamble that I'm going to read. All drugs that are taken in excess have in common direct activation of the brain reward system, which is involved in the reinforcement of behaviors and the production of memories. The pharmacologic mechanisms by which each class of drugs produces reward are different, but the drugs typically activate the system and produce feelings of pleasure, often referred to as a high. Individuals with lower level of self-control, which may reflect impairments in brain inhibitory mechanisms, may be particularly disposed to develop substance use disorders. So what they are saying is this is a problem of reward and pleasure. And this is now the definition of substance use disorders. Because of that, this was the first ever where they categorized behavioral addictions. So this is the first time gambling is now included alongside the substance use disorders, and it paves the way for other behavioral addictions, which are not officially recognized in the DSM-5, but there is a lot of chatter now, this is where it's all going, of like behavioral addictions such as actually processed food addiction, video game addiction. These are sex and love addiction. These are all things that are potentially in the pipeline for the next DSM-6. It also newly incorporates a dimensional assessment, mild, moderate, or severe. And it actually stops using the word addiction because they say it's an uncertain definition that has potentially negative connotations, and it gets confused with dependence. Now, I would say that's psychiatry's own fault. They changed the definition of dependence 5 times. But they really kind of go towards addictive disorder and substance use disorder. All right, so this is what I use when I'm diagnosing a patient. This is the DSM-5 criteria. Basically, if you have 2 or 3 of these, you get a mild disorder. If you have 4 or 5, you get a moderate disorder. And if you have more than 6 or more, you have severe use disorder. The lines are generally categorized in groups, which imply impaired control, social impairment, risky use, and then psychological or physiologic dependence. And what's interesting is that in the previous DSMs, you had to have this one, but now you don't. You don't have to have the dependence part. You could have just 2 of the other ones, and you will meet mild criteria. All right, so I'm gonna go into the neurocircuitry of addiction. This is Dr. Nora Volkow. She's the head of NIDA, which is the National Institute of Drug Abuse. This is a lot of what she works on, and she will say it is a brain disease. This is from her paper. Although much of the initial study of the neurobiology of drug addiction focused on the acute impact of drugs of abuse, analogous to comparing no drug use to drug use, the focus now is shifting to chronic administration and the acute and long-term neuroadaptive changes in the brain that result in relapse. The purpose of current neurobiological drug abuse research is to understand the genetic, epigenetic, cellular, and molecular mechanisms that mediate the transition from occasional controlled drug use to the loss of behavioral control over drug seeking and drug taking, and to chronic relapse, even after protracted abstinence, which is the hallmark of addiction. So, to summarize that again, you can use substances, and then at some point your brain crosses a Rubicon, and you have lost control. That switch occurs, and that switch is what addiction is. This is the brain's reward system. So we have natural rewards. Like, we are supposed to, if we feel love, or if we eat something really delicious, if something, there are ways that our brain interacts with things that we enjoy, is the brain sends a signal to the ventral tegmental area. And then the ventral tegmental area releases dopamine. Those are complex interactions with the ventral tegmental area, but substances directly push that button. They directly get the VTA to release dopamine. It is so much more of a powerful kind of flooding effect where you just release dopamine automatically when you're exposed to a substance. But this is a system that was built in our brain in order to respond to things that are naturally rewarding. Dopamine then travels to the nucleus accumbens, which translates that signal into the feeling of pleasure. The nucleus accumbens is attached to the hippocampus and the amygdala, and that feeling of pleasure gets encoded in the hippocampus as a memory, and the amygdala assigns emotional feelings to it as well. The other way that dopamine then communicates is the mesocortical path to the prefrontal cortex. The prefrontal cortex is the part of the brain that is involved in decision-making, planning, and regulating your behavior. So the prefrontal cortex is the part of your brain that decides, how am I going to act on all of this? And most of the time, we decide to act in a way where we seek the pleasure again. But the prefrontal cortex is a completely separate part of the brain as the part of the brain that is feeling pleasure. And I talk about this a lot with my patients, is that when you're fighting addiction, you have to use one part of your brain to fight another part of your brain, and the enemy is within. And this really does prove it. We know all of this from animal studies where we can kind of stimulate different parts of the brain and watch rats act this out. We also have created models where parts of this we form lesions in this, and we see that interrupt the behavior. We've also done studies where we feed not just animals, but people, diets that are depleted in the precursors that can help you form dopamine, and you can change people's behavior that way too. So we know, and there's also been functional MRI studies where we watch people's brains in the MRI, and we can see which parts are lighting up as they engage in these rewarding behaviors. So essentially, this is the incentive salience theory of addiction, which is you're hacking people's incentive system. Dopamine signaling is what we use to motivate our seeking reward. This is a really good book, by the way, The Hacking of the American Mind, which basically explains how everything has turned into a dopamine hack. Our food system, our social media, our video games, gambling. We're giving everyone the ability to gamble on their phone, and then substances. And it's basically everything is now a dopamine hack, because dopamine hacks are also really good for capitalism. Drugs are the hijack. They're the biggest hijack of all, and I'll show you why. But it goes from just liking something to wanting something, because it is changing behavior. All right, the addiction cycle starts as a binge, intoxication, then withdrawal, negative effect, and then back to preoccupation, anticipation. And at first, that's motivated by the positive reward that you get, that pleasure reward. But over time, as you descend into that cycle, you actually start to be motivated by compulsivity. So impulsivity is when you're chasing positive reward, and then compulsivity is when you are actually chasing relief from negative consequences. And this is what happens as people descend into addiction. They start to just try to avoid the negative state. I'm not going to explain this diagram too much, other than to show this is a brain diagram, and that there are very specific receptors for opioids, cannabis, nicotine, GABA. GABA is the receptor for alcohol and sedatives, and this is just to show that there are direct sites in the brain where these attach and stimulate. Okay, I have seen this personally in my practice, and I know this is another proof that this is true, is that people with Parkinson's. Parkinson's is a disease where dopaminergic motor neurons get depleted, and the treatment, and that causes motor dysfunction. So people with Parkinson's have like tremors and rigidity. And one of the treatments that we give them is carbidopa-levodopa, which is the precursor to dopamine. And we do that to try to improve their motor function. And one of the side effects of carbidopa-levodopa is addiction. So I have personally seen this twice, where a Parkinson's patient, given carbidopa-levodopa, developed a horrendous gambling problem. And they went from like a person who was just suffering a motor disease to someone who lost their family $2 million at the casino. I also saw another Parkinson's patient taking carbidopa-levodopa, develop an addiction to carbidopa-levodopa itself, and started just taking all their medicine all the time. So I have personally witnessed that, but also it's described in literature. It's actually on a package insert as a side effect of carbidopa-levodopa. You might develop crippling addictions. All right, so how do we treat all of this? So historically, psychiatric treatment was kind of scary and harmful, and we did the same thing to people suffering addiction. There was bleeding, blistering, mercury-based treatments, extreme diets, other narcotics. So cocaine was developed to treat alcohol and opioid addiction. And then there was a thought that it was passed on through genetics, which that still does. That is still part of the model, but so one of the thoughts was, let's sterilize people so that they don't pass it on. Electroconvulsive therapies and lobotomies. So psych was a brutal treatment paradigm. And then I also told you, right, that like societally we were criminalizing more and more. So society was punishing and medicine was punishing. So this is what resulted in the creation of Alcoholics Anonymous in 1935. This is Bill Wilson and Bob Smith, who are both recovering alcoholics themselves, who were proposing a new way to recover from alcoholism. They published what's called the Big Book. It's Alcoholics Anonymous, the story of how many thousands of men and women have recovered from alcoholism in 1939. It established the 12-step method, and it also was based on mutual help groups and peer support. And I think this really was truly a reaction of just like, how can we do this more humanely? Medicine and society are both kind of, harsh. This is the 12 steps. I won't necessarily read all of it, but step 12 is essentially a spiritual awakening. When I look at the 12 steps and I look at how this has become the dominant form of sort of treatment in the United States. When I look at this doesn't look particularly medical to me, but this is what has been helping a huge chunk of the population for the last, since 1939. All right, so in 1990, the United States Institute of Medicine was like, we should study AA to see if it's actually effective, because everyone's using it. And so this was a lot of papers came out about now we are medically studying AA itself, right? So I said AA doesn't sound too medical, but we actually have a lot of medical research about AA. So this is a literature review in 2009 that said, okay, here's everything that we know about AA, and can we determine causality? So the 6 criterion for establishing causation are magnitude of effect, dose-response effect, consistent effect, temporally accurate effects, specific effects, and plausibility. And they determined that AA meets 1, 2, 3, 4, and 6, meaning if you go to more AA, you're probably more likely to be abstinent. If you are going temporally to AA meetings, more likely to be abstinent. If you're going consistently, and it's plausible, right, that you going to all of this, you would stop drinking. But interestingly, it failed at criteria 5, meaning it was very unclear if it was specifically AA that was doing this, or just sort of the whole engaging with the groups and support. And actually the studies on this were really mixed about like whether AA is helping people or harming some people. Some people were kind of turned off by AA. So AA has a specific effect, but they couldn't really figure it out. This is another study of like what is it about AA that helps people. And interestingly, I think AA started to figure this out themselves because AA published a second work called Living Sober, which is sort of the methods of how to not drink. And Living Sober was published in 1975, and they started to see more and more people engage in AA, and the diversity of who was engaging in AA. There are people that, like, I don't know, actually say they're atheist, right? So how does like an atheist engage in AA if AA is really calling upon a higher power and having a spiritual awakening? So even AA realized that there are more people diversely engaging with the 12 steps, and so they published like that second work. This study basically says that the beneficial effects from AA seem to be more due to social, cognitive, and affective behavior change mechanisms, and not because every single person is having a spiritual awakening at step 12. Some people still say they have had that, but it's probably more acting it all out by going to meetings and getting the spiritual and personal support from peer groups. All right, so this is a survey. This is the National Recovery Survey of the U.S. population who identify as having had an alcohol or drug problem but no longer do. That's not necessarily the same as having an addiction. It's just people who say, I had a problem with this once, but I'm done. The total prevalence of Americans that are estimated to be in recovery is about 9%. That's not the exact same prevalence as people currently suffering with addictions, which we think is closer to 12%. Of the people that identify as in recovery, 53% said they needed help. Now, 46% said they kind of did it naturally. And again, it's because I'm not really quite sure that this is people that had an addiction. Potentially, maybe you drank to excess in college and then had like a DUI or something and then you stopped drinking. That would have fallen potentially in this category, and I don't know that the person ever had like an alcohol addiction or just had like one bad event. But this is the best survey that we have. Of the 53% that needed help, this is what they said helped them. So 27% said, sorry, it's 20% of the total of the people in recovery. 27% of people in recovery used professionally assisted recovery support. 21% used recovery support services, and 45% used mutual health groups. And I circled in red the ones that are 12-step based. So this is by far what most people are using to recover. They are using mutual health groups. And I wanted to highlight that medication, 8%. So medication not so used, actually used kind of rarely. This is from the American Society of Addiction Medicine that articulates where treatment can be found, and they include these different level settings. Level 4 inpatient, which is medically managed, that's like a hospital-based detox. That's only one area that this is done. Essentially, these programs are different types of residential programs, different intensive outpatient and partial hospitalization programs. Maybe you are going to be in a traditional healthcare setting again, in like a clinic. I have a level 1 clinic, and then our hospital has level 4 services because we can detox people in the hospital. But all of these other programs are usually outside of traditional healthcare. And that's probably my guess as to why medications are not getting used. That most of these programs don't even really have physicians in them. In fact, a lot of them are still peer recovery based. Even really, really expensive, fancy substance use programs like Betty Ford. Betty Ford still exists in kind of a separate world. Like when you go and you get your substance use problem addressed, you go to some place like Betty Ford. You don't go to Cleveland Clinic. And so the substance use world is not only separate from traditional healthcare, it's sometimes even separate from traditional psychiatric care as well. So a lot of our psych hospitals, once they're done doing psychiatric treatment, they say, oh, you gotta go get your substance use problem treated over here, and they'll transfer you to another location. So this is probably why the disease model hasn't really permeated through treatment, is because we have separated this. The other major influence here is what do insurance companies cover? And insurance companies don't always cover this care, and they articulate it as a separate benefit that has nothing to do with your medical health care. Okay, so I just said people are not using medicines widely, but I do think that medicines have a lot of evidence for them, and there's probably a lot of contextual reasons why medicines aren't getting brought to the patients. We have all of these medicines for all of these different use disorders. The best evidence that we have is for opioid use disorder. Methadone and buprenorphine have a lot of effectiveness in studies going pretty far back. We do have medicines for alcohol use disorder. We have less medicine options for stimulant use disorder, like cocaine and methamphetamine, and that has become a really big problem now because methamphetamine use is on the rise, actually just consistently on the rise. Cannabis use disorder, we have some evidence for N-acetylcysteine, benzos, and then we do have really good evidence for nicotine use disorder around the medications, varenicline and nicotine patches and stuff. So we have various levels of evidence, but we do have evidence, we do have research on the utility of these medications. Opioid use disorder, it's a lot of what I spend my time on. Opioid use disorder, we have the best evidence. The medications, going back since 1965, there has been proven that if you can put people on medications, you can get them out of this roller coaster. So this is that addiction cycle I talked about, which is at first you're chasing positive rewards, and then at some point you just start trying to avoid negative rewards. And you are using drugs to get yourself out of a state of withdrawal and bring yourself back to normal feeling. When you get put on medication, that is when you can stay in normality stably. And that action, just stopping this cycle of up and down, up and down, up and down, and just getting people to stability, improves literally everything about their life. It decreases their risk of transmitting HIV and hepatitis. It decreases their risk of death. It makes them a more functional, healthy, employed person. They have better social function. They're not going to jail. So it really does improve all of these sort of objectively important outcomes. And we have papers going back 1965 showing all of this. What we know that doesn't work, we know that detox doesn't work. So detox is when you symptomatically treat the physiologic symptoms of withdrawal. And it's basically a short-term solution. You can get people through withdrawal, but it won't necessarily treat the long-term brain disease. And so, and in fact, it can actually increase their risk if you detox someone without any kind of long-term plan for what they're going to do with their addiction at the end of a 5-day detox. What you end up doing is you end up changing their body's tolerance, and then if they then leave and relapse, it's more likely to be fatal. So detox actually increases harm in the long term. Now, it is a necessary step if people are trying to quit. But I talk about this all the time, is that we shouldn't be focusing on quitting. We should be focusing on what are we going to do instead. So a lot of times, like, the patient is in front of me in the hospital, and I'm seeing them, they've already quit, assuming they're not drinking or using drugs right in front of me. They have already quit. So talking about quitting is kind of the wrong framing. We got to talk about what are we going to do now instead of returning to drugs. And that's why detox is such a short-term perspective. A lot of programs, people like go, they check in, they're like, I'm going to quit this drug and I'll be done in 5 days. That's not really how this works. And so we should be getting people stabilized on medication is what we should be doing with the detox period. All right, this is some, this is a study of how many people are using medications for opioid use disorder. So 4% of US adults need treatment for opioid use disorder, and only 25% of that 4% ends up getting medication. This is for alcohol use disorder. 27 million adults have alcohol use disorder. Less than 10% get any treatment at all, and only 2.4% are offered medication. Now, the reason I'm talking so much about medication is this has changed now to an actual public health crisis. So a lot of talks that I attend start with these slides, and I actually waited purposely to present this part of this much later in the presentation, because I really think like addiction was more of like this intellectual conception of like, you know, what is it about addiction? We have to figure it out. And then at some point, deaths started to skyrocket. And when deaths started to skyrocket, it changed everything. It changed, how are we doing this now? We can't just like sit here and recategorize addiction into categories endlessly. We have to do something. And so substance-related deaths have been skyrocketing. This shows alcohol and drug deaths, and then along with suicide deaths, because a lot of people commit suicide using substances. This is by substance itself, so you can see that the real rise has been with synthetic opioids. This is with like fentanyl contaminating the heroin supply. You just see deaths skyrocket since basically 2014. All right, the other slide was that it was a uniquely American problem, that we have, the United States has way more drug-related deaths than every other country in the world. And that was a little bar graph to show that. So I don't know why that slide's possessed. All right, so I'm going to talk about addiction medicine. This is actually what I'm board certified in, is addiction medicine, and not addiction psychiatry. And so addiction medicine was started in the 1950s by physicians who struggled with addiction themselves and dedicated themselves to the care of these patients. That's when they formed the American Society of Addiction Medicine. However, in 1985, psychiatrists formed the American Academy of Addiction Psychiatry, and they got to the American Board of Medical Specialties first, and they said, we want the specialty addiction psychiatry to be our specialty because we are psychiatrists and we understand the brain, and our understanding is superior to people's whose understanding of addiction is just from their own lived experience. And so they kind of got the turf. They claimed the turf, and ever since then, addiction medicine was trying to get recognized as a specialty, and they officially succeeded in 2016. So this is what I'm certified under. I am not a psychiatrist. And this paves the way for new training programs. I am faculty in an addiction medicine fellowship program at Rush. We basically started a fellowship the second this field got recognized as a field. So our fellowship is about, it's about 8 years old now. And the idea here is to expand the workforce. If you are waiting for psychiatrists to start tackling addiction, that is not enough people to tackle this tidal wave of deaths. So you need people who are willing to do the work, and this now includes people who are medically trained in other fields. So my initial field was emergency medicine. Our fellows have come from internal medicine, family medicine, OB-GYN, pediatrics. And you can now specialize in addiction medicine from those fields as well. I do think 1/3 of people who are part of ASAM are in recovery themselves. This is my team at Rush. So this is an addiction medicine consult team, and the idea is to bring addiction medicine back into traditional healthcare and not have it be kind of in these this parallel world that doesn't intersect with medicine. And so when people are admitted to the hospital and they have addictions, if they're admitted to the hospital for another reason, like let's say you get admitted because you have pneumonia, but someone needs to be there to understand that you're also going to probably go through drug and alcohol withdrawal. And someone needs to be compassionate and offering treatment for that while you also try to heal from pneumonia. So our team is sort of the ambassador between the two worlds and also medication forward, with the idea of we need to be offering medication more because we are in a public health crisis. I will give you an example of a debate I had with an addiction psychiatrist. So this is the difference between addiction medicine, me, and addiction psych. Sorry if any of you are addiction psych, but an addiction psychiatrist told me I need to do an assessment for 2 hours to really understand who the person is so that I can make an appropriate medical recommendation of what medication to start in that person. And I said to them, the person who is suffering from withdrawal has already run out of the room. You cannot do a 2-hour assessment. You have to offer them medication to stabilize their symptoms so that you can even have that conversation. So it's very medication forward. Now, I will say, it's not that I believe that the conversation stops there. I'm not saying that medication and nothing else, but you do need to realize that there is a physiologic suffering that needs to be alleviated for you to be able to proceed. Okay, this is another big thing that I could include in the next section called controversies. But harm reduction actually does have a decent amount of medical evidence for, and it's, again, another response to the crisis that we're in, where the focus of harm reduction is not necessarily to treat the addiction per se, but to just try to reduce the harm of it all and to try to save lives. And the idea is you don't want people to not come and get care because they're not yet ready to quit drugs. You want people who are still using drugs to still kind of get their wounds tended to get clean supplies, to get testing for HIV and Hep C, and you are trying to, decrease their death and morbidity, not just treat the addiction kind of purely. I view harm reduction as a sort of, essentially, don't let perfect be the enemy of the good kind of thing. This is also when I'm helping people decrease their use. If someone decreases but doesn't quit entirely, I still consider that a win. And just moving towards safer and safer practices. There's a lot of evidence for harm reduction. Syringe service programs actually have a lot of evidence saying that they decrease HIV transmission rates, decrease hepatitis. There's also improving access to healthcare. So sometimes if you come there to get clean supplies, they'll offer you vaccines. You know, if you come there to get clean supplies, you could get your wounds checked on. Also, naloxone distribution. I spend a lot of my time and effort distributing naloxone, which is the overdose reversal agent. This has a lot of good evidence that it creates a culture of safety. Whenever I have a patient and I say, do you carry naloxone? Sometimes they say, yeah, and I actually reversed my friend the other day. He overdosed, and a lot of times they didn't engage in any other treatment. They were using drugs, he saved his friend, and the next day they went back to using drugs. But I still tell that patient, you saved his life, thank you. And so I view this approach as essentially a very sort of unconditional love kind of approach, to be honest. All right, so controversies is like my last section. All right, so this was an article from the New York Times last year, Rethinking Addiction as a Chronic Brain Disease. And there's still a debate about the model, and there's a pendulum swing back against getting too medical. So I view like our mission is to offer more medication because it's so underutilized, but I totally understand when people say, well, now you're getting too medical, you still have to treat the person holistically and like psychosocially. I totally get that. If you are just offering medicine and nothing else, you are not like taking care of your patient holistically. So I get that backlash. I also think this is a little bit of a backlash between the psychiatrists and the addiction medicine turf war. The psychiatrists are like, no, we need to understand the person. And I agree, psychiatrists, I agree. But I do still think medicine is underutilized. And then how chronic. Some people really don't like the idea that you kind of suffer this forever. I do think of this as a chronic disease. When patients say to me, how dare you say I have never recovered, I say, no, you have recovered and it is in remission. But the way I describe the chronic nature of it is that you have a memory and a feeling that will be in your brain forever and it can't go back to blank slate. And so that's what I mean by chronic. Not that you're damned forever to suffer from addiction, but it's just that you will have a memory that other people who never had addictions don't have. And it's in there. And that's what I mean by chronic. But this does come up with patients. Patients really get upset by the idea that they have this disease forever. And that for them it feels very hopeless. And I say, no. I believe everyone can recover. And I believe that it is probably the most triumphant moment of humanity to recover from this. So I'm not a pessimist. I am an optimist. But you will have a memory of this that, like I said, other people don't have. Controversies as well. This could be an entire talk itself, and it's my last slide, really. But do people with addictions have free will? I'm just gonna leave it there. Do they have free will? The way I'll talk about this is that we don't know. We haven't decided as a culture. So in 34 states, so all states have involuntary commitment laws, but only 34 states have commitment laws for substance use disorder. And like weirdly, in Rhode Island, you can only commit for alcohol use disorder. And then it really varies by state what kind of treatment can be ordered by a judge. The average length is something like 90 days of treatment, but that varies too. And then 24 states define penalties for false commitment. So I think the reason why people are afraid to commit is you don't want to abuse the power of commitment. You don't want to go back to a century ago where we were throwing people in asylums and like locking them up. But the alternative of this is, can people be so out of control from their addiction that they need to be protected from themselves? And I would say we have said yes in 34 states. Our state, Illinois, does not have this law. And so I cannot commit anyone against their will for their substance use. I do believe, I have seen it. I do not think everyone with addiction has lost their free will, because I have seen people who take control of their lives and recover. And so I do believe that most people with addiction still have free will, but I do believe that there comes a severity where you have gotten so far that you need to be protected from yourself. And I think I've seen it. I think I've seen it amongst my patients, where I'm watching them kind of die in front of me, still drinking, even as they get more and more encephalopathic. I view this as similar to other brain diseases, like if you have a brain tumor or if you have Parkinson's or something, you still have free will until you get to a severe enough place where enough of your brain has become diseased. So I just think it's kind of a threshold thing. I don't think it's yes or no. If you have addiction, yes or no, you have free will. But I feel like, having worked in this space, I think I've witnessed it, where I think people need to be protected from themselves. And that's not that, I would say that it's very rare, actually. I would say it's like 2% of the patients I treat. I think they maybe need to be locked up in order for them to stop this. But I would say the vast majority of people, I am appealing to their own free will when I'm asking them to enter into treatment. All right, this is in summary. Okay, There has been a disease model proposed for addiction for centuries. The model has been revised multiple times, and we aren't sure we're at the final conceptualization yet, but there is a clear biological basis for addiction in the brain. Addiction can be medically treated, but also psychosocially treated, and there's evidence for both. And the epidemic of substance-related death has brought new practitioners and new approaches. That's it.
Thank you so much, Dr.